Good evening to everybody, and welcome to the EASL Studio, your weekly hepatology broadcast news. My name is Bogdan Procopet, and I'm a hepatologist in Cluj-Napoca, in Romania. In the recent years, non-invasive techniques were validated as very easy-to-use methods to identify patients with compensated advanced liver disease and to identify if this patient have clinical significant portal hypertension and therefore are at risk of decompensation. Based on relatively new data, once we identify these patients with portal hypertension, we should begin non-selective beta blockers to prevent the first decompensation. Accordingly, the last Baveno consensus recommends the use of non-invasive methods like elastography to identify patients with portal hypertension and to start beta blockers, non-selective beta blockers, without needing endoscopy or HVPG. In today's episode, we will discuss with Atoosa Rabiee from Washington, Maria Papp from Debrecen, and Thomas Reiberger from Vienna, how we will diagnose clinical significant portal hypertension and varices in 2024, and in which condition we still need invasive method. So I would like to start by asking Thomas, what is the future of HVPG and in which clinical context is still recommended to use?
Thank you, Bogdan, and hello, everyone. It is obviously one of my favorite questions to speak about HVPG and portal hypertension. And as you said, I think the non-invasive tests have in many instances replaced or at least led to a decreased use of HVPG. I do still think it is the gold standard if you want to assess severity of portal hypertension and want to actually know the actual value by this indirect measurement, and thereby it's actually a minimal invasive technique and is still preferred to more invasive techniques where you would directly puncture the portal vein, for example. I do want to stress that the concept of clinically significant portal hypertension that we use today for risk stratification is really based on HVPG. And so this magic threshold of 10 millimeters of mercury is really a watershed moment where the patients are at an increased risk for decompensation, development of varices and ascites. I also want to highlight other thresholds like 12 millimeters of mercury where patients may experience variceal bleeding. And for a long time, this has been the magic threshold where when you use non-selective beta blockers, you want to go below that, then you know your patients are protected from bleeding. And then there is 60 millimeters of mercury where the risk of decompensation is even further increased, and 20 millimeters of mercury where you often need more invasive methods, such as a transjugular intrahepatic portosystemic shunt to control bleeding or refractory ascites. So now with all this evidence, I do think that in near future, there is more and more non-invasive methods available, and also the evidence will be stronger to replace HVPG measurement, because this is also resource intense and requires significant expertise and methodology. And so I do think it should be reserved in today's practice for tertiary care centers and places where trials are conducted. Why I mentioned trials? Because I do think that when we study drugs that have a strong impact on fibrosis, such as antifibrotic drugs or stronger etiological treatment, it's even called for HVPG measurement in phase 2 trials, such as by advice of the FDA. So in these situations where we really want to know how portal pressure changes, how a treatment affects fibrosis, which is the main component of portal hypertension, then I would think we should still use it. However, as I said, confirmed to a strong, to a confined setting with the tertiary and high volume centers.
Indeed, thank you. Among all the non-invasive methods, liver stiffness measurement, it is the most validated method by now. Now I would like to ask Atoosa, how easy to be implemented in the clinical practice, especially in US, and what is the normal trajectory of a patient with suspicion of advanced liver disease?
Thank you, Bogdan. It's great to be back on EASL Studio. Thank you for having me back. So, transient elastography in the US remains among the most widely used methods, first to stage disease, and now more so to assess risk of decompensation or need to do an upper endoscopy. There are GI offices that use this as point of care. There are some radiologists that do this. It is very important to note that it should still be done in a high volume center, and it should be interpreted with a knowledge of hepatology, whether it's a hepatologist or somebody who sees these patients in the context of clinical history, other labs. And I'm not just mentioning IQR, but also patient's history, active alcohol use, history of heart failure, other lab work, other imaging characteristics. So traditionally, I think it has been used very widely, actually, to risk stratify and assess fibrosis. For the most healthcare system, it is really difficult to offer this to every single patient with underlying liver disease. So most healthcare systems try to risk stratify with easier tests such as FIB4 that is widely available and now can be incorporated into electronic health record. And only refer those patients with indeterminate or advanced stage of fibrosis to hepatology. Now, since AASLD guidelines adopted, Baveno 7 recommendations as far as using transient elastography to basically assess disease progression and assessment of presence of clinically significant portal hypertension, I suspect that we're going to see more and more patients being referred to hepatology for this specific reason. I do want to say that what probably needs to happen to adopt this even more in the US is specific studies that would address this in patient population with MASLD and that specifically higher BMI. Now, we do have Anticipate NASH that provides kind of a framework, but we do know that patients with MASLD, the thresholds are different with comparable cutoffs. If you compare patients with MASLD and alcohol-related liver disease, there's lower risk of liver-related events. So I do think this is an unmet need, and I'm hopeful that more and more studies will be done in this specific population to make it available specifically in the US.
Indeed, you very well pointed the need where is need to more data. Now, in the recent years, we know that there are some factors that may influence the measurement, the elastography measurement. I would like to ask Maria, how relevant is the etiology when we apply the elastography methods, and what are the possible interfering factors?
Thank you very much, Bogdan, and good afternoon for everybody. So important to know that guideline suggestion for liver stiffness measurement and spleen stiffness measurement cutoff values are based on those studies including patient active HCV or HBV infection. So despite ever-increasing number of studies with promising results, needs more data whether the same cutoff can be applied also in the HCV patient with actively treating and achieving SVR or other liver etiology such as MASLD, autoimmune hepatitis, or cholestatic autoimmune disease. So the ability to achieve consistent and reproducible measurement depends on several critical factors, and multiple confounders affect both the liver stiffness measurement and also the spleen stiffness measurement that can lead to false positive diagnosis for fibrosis and clinically significant portal hypertension. And this is what Atoosa mentioned, that not only the measurement of LSM or SSM is important, but the whole context when we assess the patient. firstly, so there are some technical aspects and patient-related factors, but if we consider your questions, the liver etiologies, we can say that local and systemic inflammation, high-level transaminases increase liver stiffness values, likely due to the inflammatory cell infiltration and hepatocellular swelling. However, spleen stiffness values suggested to be less biased by inflammation compared to liver stiffness. And a very good example is the autoimmune hepatitis, which is one of my favorite liver diseases. So in patients with autoimmune hepatitis with the immunosuppressive treatment for less than 3 months, liver stiffness correlates better with histological grading than with staging. In patients who treated for 6 months or longer, accuracy is excellent for detection of advanced fibrosis. And there was a very interesting study which proved that in individuals with active hepatitis, the combination diagnostic approach, SSM and LSM, so including both, might provide a more accurate estimation of the liver fibrosis as compared to liver stiffness measurement. And there are 2 additional I think a disease factor, like in primary sclerosing cholangitis. So in primary sclerosing cholangitis, there are a patchy fibrosis distribution. So a spatial heterogeneity of hepatic fibrosis as we compare to the rather homogeneous viral hepatitis-related cirrhosis. And this is a confounder and is also the mechanical cholestasis because the mechanical cholestasis increase the liver stiffness, the bile duct obstruction leading to an increased pressure, edema, swelling, and whatsoever. And mainly in this population, ELF test may be more reliable non-invasive test for clinically significant portal hypertension than liver stiffness measurement for the risk stratification. And lastly, the pre-sinusoidal component of the portal hypertension in patient in muscle D or primary biliary cholangitis would not reflect by liver stiffness measurement, such as not by HVPG value. So, but might be captured by spleen stiffness. So combining the 2 elastometry would be even more valuable in this patient population.
Yes, indeed. And not to forget, and I would like to stress that liver stiffness measurement should be always measured in the fasting condition. And also, because you mentioned the muscle patient, that all frequently they have comorbidities like cardiac disease. Also, hepatic congestion may falsely increase, I mean, not falsely increase the liver stiffness, but may overestimate interpretation of fibrosis. Thank you very much. Now, almost every ultrasound machine has an elastography module, and technologies such as shear-wave elastography or RFE are widely available. But Thomas, I would like to ask you if all these techniques are equivalent to the transient elastographies, and can we use all these techniques in clinical practice, or we should wait until extensive validation of these new techniques?
Yeah, thank you. I think this is a really important question. You know, since we use ultrasound in daily liver practice, not only at radiology but also at GI and hepatology clinics, and the shear wave elastography system is available, as you said, in most of these machines. Now, having that said, it's not the same way to measure elastography. It is the name is acoustic radiation force impulse. So this is the way the shear wave is generated, and it's different from a mechanical compression, such as vibration-controlled transient elastography. So just by nature, how you do the method, it's different, and that explains why the values cannot be really converted directly from one machine to the other, and clearly also not from RFE-based shear wave to vibration-controlled transient elastography. So that has created actually a lot of confusion, and I think this is one of the reasons why also RFE has not been so well adopted in clinical practice as FibroScan. Another reason is likely because the FibroScan has just the way the results are read. You immediately see the IQR And if unreliable measurements are not even displayed. So this is probably another reason. So the reliability of measurements is immediately evident, so to say. So still, I do think that the RFI-based technologies are of great value. And especially if you are trained well on the machine and if you are also an experienced ultrasonographer, they have a huge role in clinical practice. On the one hand, because the techniques have been also improved, and you see this quality indicators directly in real time, especially for the 2D shear wave elastography machine. You have confidence maps available. You also see immediately the IQR, so you have measures of reliability. On the other hand, you also can use the machine by nature also for the B mode images and see directly signs of portal hypertension, which is splenomegaly, spleen volume, portosystemic collaterals. You can look in perfusion, you can look into portal vein diameter. And I do think those patients with advanced chronic liver disease, cirrhosis, that need to undergo HCC screening anyway, and this is where ultrasound is recommended. We should use it if it's available, and at the same time, we should also know the limitations. And the last thing I want to mention, because it has not been mentioned so far, and I think it's probably the most important thing that we learn from transient elastography, is the rule of 5 kPa. This is actually where advanced chronic liver disease, or specifically compensated advanced chronic liver disease, was first mentioned in Baveno 6, with a cutoff of 10 suggesting, and with a cutoff of 15 making advanced chronic liver disease very, very likely, or even confirmed if you repeat it. Now, as I said, you cannot directly convert these values to the RFI-based techniques. However, there is the rule of 4 that was very recently even updated with the World Federation in Ultrasound in Medicine and Biology, with a very useful cutoff at 21. So previously, the rule of 4 was 5, 9, 13, 17, with 17 suggesting CSPH. And now we have the cutoff value of 21 kPa for the RFI-based technique, which makes CSPH very likely. And I think this is the last thing I want to mention about the RFI-based technologies. It's useful. You should know the cutoffs. You should know the limitations. And when you go back to FibroScan, use the rule of 5. Very, very useful in clinical practice.
Yes, indeed. And thank you for mentioning for the rule of 5. And we still need to wait a little bit until the rule of 4 would be much more validated and start treating accordingly. Now, Maria, you mentioned the spleen stiffness, and there is data recently that spleen stiffness proved to be even better correlated with HVPG. So what would you recommend? Liver stiffness, spleen stiffness, or both?
Thank you very much for the questions. I think to answer this correctly, there are two important physiology aspects which need to mention. So firstly, spleen stiffness not only reflects the mechanical, so the static component of the hepatic resistance due to the liver fibrosis that is captured by liver stiffness, but may also capture the dynamic pre-sinusoidal vasoconstriction and congestion of the portal blood flow, and also the portal hypertension-induced splenic fibrosis. Thus, spleen stiffness is a direct and a dynamic surrogate of the portal pressure compared to liver stiffness. And secondly, the good correlation are well established between the liver stiffness and HVPG values, and also the spleen stiffness and HVPG values, but there are substantial differences. So spleen stiffness has a stronger correlation, as you mentioned, because the correlation is really the same in the whole range of the HVPG. And this suggests that the increase in spleen stiffness is closely tied with the progression of the portal hypertension from early to late stage of the cirrhosis. By contrast, liver stiffness correlation with HVPG is at 2 phases. Excellent in case of HVPG values less than 12 millimeter of mercury, but poor with above this threshold. So considering this physiology, so we can say that for the diagnosis of clinically significant portal hypertension with certain cutoff, both techniques are really valid. And but to diagnose of high-risk esophageal varices that require treatment, combining the two types of elastometry, the results are much better in avoiding screening endoscopy. So spleen stiffness-based algorithm with spleen stiffness value under than 40 kilopascal proved to be superior to Bowen 06 criteria in ruling out high-risk esophageal varices. So approximately double the number of spared endoscopies without raising the rate of miss high risk of varices. And I think so combination is really meaningful. And there is, I think, also an advantage in the literature, the SSM measurement is. So it's a very promising tool for the prediction of the acute and chronic hemodynamic changes. That is a clear advantages of liver stiffness measurement over clear advantages of the spleen stiffness measurement over the liver stiffness measurement, because SSM, but not LSM, is able to predict the clinically significant portal hypertension treatment response for non-selective beta blocker or TIPS. So of course, we need more trials, but this is a really, really promising field. So as a summary, spleen stiffness might complement liver stiffness in everyday clinical practice. We can combine them together to precise diagnose and monitor the clinically significant portal hypertension, including response to therapy.
Thank you very much. And indeed, probably both combining both techniques would be ideal. And I can imagine the clinical scenario of portal vein thrombosis, which might include variation in the interpretation. So this is an interesting field. Now you mentioned something very relevant, that is treatment response. And we know that treatment response is defined by the increase in HVPG, and it is very well correlated with a better prognostics. Now, I would like to put the tough question to Atoosa, and I'm sorry for that. What is the potential role of elastography in monitoring treatment response to portal hypertension treatment?
So so let me first start by saying, if we are talking about specific treatments such as non-selective beta blocker, I think, as Maria mentioned, transient elastography lives a little bit to imagination, and we probably are stuck with HVPG. Now, I want to then backtrack and say, when you talk about treatment of portal hypertension with removing etiology, such as patients who get hepatitis C treated or stop drinking, there is pretty good correlation that those patients, assuming there's no ongoing injury, you treat their hepatitis C, their liver stiffness is consistently below 12, and they have no ongoing injury, they can hopefully be cared for by primary care physicians with just HCC surveillance, but not be under the care of GI and hepatology. For non-selective beta blocker and treatment response, I do agree with Maria, but I will throw this in that on individual level, I don't think that whether it is transient elastography, spleen stiffness, or HVPG, I'm sold that has much role in assessment of treatment response to non-selective beta blocker. Juan Abraldes did this very elegant study of analysis of 900 patients. The outcome measurement was HVPG in versus treated patients with carvedilol or propranolol versus placebo, and the pooled variability ratio in all these studies, which included more than 900 patients, showed pretty homogeneous HVPG response to non-selective beta blocker at an individual level. So for the patient that you're starting non-selective beta blocker in clinic, I'm not sure if it's as relevant. Now, if there are new medication and you want to assess efficacy, I would certainly go back to Thomas, right? And say that HVPG is probably what you're going to be using to assess treatment response. That's kind of my non-answer to that.
No, you were perfectly right. Maybe we don't need a tool to assess response to non-selective beta blockers, as you very well mentioned. While in the study, we still have a role for HVPG. Now, we still have a few minutes, so I would like to be a little bit provocative, and I want all of your brief opinion about how far away are we in the clinical practice from abandoning the screening endoscopy for varices to a strictly therapeutic endoscopy, like band ligation where it needed?
I do think that we are more far away as we should be. It's still very, very commonly used. And I do think that on the one hand, we can spare a lot of unnecessary endoscopies, which is, costs for healthcare system that can be used more rationally and more patient-directed, so to say. I do think we have to educate the endoscopists, our GI colleagues, a lot on this. Because it is still risk for patients as well, and not only economically for the healthcare system. So two messages. We can spare really endoscopies in patients with cirrhosis that have a liver stiffness below 20 combined with the normal platelet counts. These patients don't have high-risk varices, okay? However, you cannot directly translate this to absence of CSPH. CSPH can only be non-invasively excluded if the liver stiffness is below 15 and normal platelet counts. Now you go to the other end of the spectrum and you have the cutoff for ruling in, which is at the FibroScan level for liver stiffness at 25. And I actually would be positive to start patients on carvedilol because the overall harm is very low if you do that strategy. Well, that leaves a small gray zone. And here I'm actually with Maria to use spleen stiffness on top of that. With the new techniques available, especially with the new probe for the FibroScan, the spleen stiffness seems to be very valuable. And if you have a high liver stiffness, you have a high spleen stiffness with 40 or 50, 50 is more specific, and there's also thrombocytopenia. I think you can just start the beta blocker without, and I'm quite sure that I do something beneficial for my patient.
Thank you. Maria, we will abandon the screening endoscopy.
I think, yes, we are going on this route, but we also have to mention that the new spleen elastography technique with 100 Hz spleen transient elastography probe is a very new one. And all studies which really support that using the clinical practice was based on the conventional 50 Hz liver transient elastography probe. I really believe that it will be the future, but I think we need more data. But more and more study in the last years came up that completion with Bogdan 06 criteria with spleen stiffness based algorithm double the number of spared endoscopy without raising the rate of the missed high risk varices. So the story started.
Atoosa?
I mean, I agree with everything that Thomas and Maria said. I recently gave a talk and I was asked, so have you adopted this in your practice? And I said, yes, as of like 3 years ago. So I still think, yes, absolutely. Our GI colleagues have to be educated on the fact that you can absolutely avoid doing a screening endoscopy. Now, if you are part of that group that still says, well, the subgroup of the people who had small varices in Predesi trial had much more beneficial effect with carvedilol. I would say if you really absolutely need to do that endoscopy, do it. But I don't think in this day and age there is any point in doing banding as primary prophylaxis as opposed to carvedilol. So I would say that I would be hard pressed to accept that as an initial option for a patient, and perhaps that's doing a disservice to the patient to band as primary prophylaxis.
Thank you very much. And not to forget that now endohepatology is more and more present in the field of hepatology. Well, I think the time is up, and I would like to thank to our guest and the audience who hopefully enjoyed our discussion. And next week, tune in for an episode on drug-induced liver injury with experts from the EASL DD Consortium. And thank you very much. And remember to become a member. Enjoy the EASL family. Goodbye.
Thank you.